let's discuss chapter number 3 of ATLS. Okay. So chapter number 3 is on based of shock. So shock does not result from an isolated brain injury unless the brain stem is involved. Okay. Then hemorrhage is most common cause of shock in trauma patient, and this is most common cause of death also in trauma. So what is cardiac output? So cardiac output is defined as volume of blood pumped by the heart per minute. Okay, per minute. So it is multiplied by the heart rate and stroke volume, and stroke volume is determined by the preload, myocardial contractility and afterload. Okay, so cardiac output is heart rate multiplied by stroke volume. So preload, myocardial contractility and afterload. So this is the stroke volume. Okay. So what is preload? Preload is venous blood return. Okay. So venous system considered as reservoir or capacitance. Okay. So first component, blood that would remain in this capacitance, okay, and does not contribute to the mean systemic venous pressure. Okay. So we are talking about the venous system. So the first component is blood that would remain in capacitance and that does not contribute to mean systemic venous pressure. The second component is venous volume that contribute to the mean systemic venous pressure. Nearly 70% of the total blood volume is located in the venous circuit. This line is important. 70% of the total blood volume is in venous circuit. Okay. And the afterload is also known as peripheral vascular resistance, that is systemic. Okay. So blood loss pathophysiology. So early circulatory response to blood loss is vasoconstriction. Okay, but vasoconstriction where cutaneous, muscular and visceral circulation to preserve blood flow to the kidney, heart and brain. Okay, important. This is very important line. So preserve blood flow to the kidney. Start from the top, brain, heart and kidney. Okay. Remember, liver is not included. So brain, heart and kidney. So tachycardia is earliest measurable circulatory sign of shock. This is very important line. Huh? Okay. So most effective method of restoring adequate cardiac output, end organ perfusion and tissue oxygenation is restore venous return to normal by locating and stopping the source of bleeding. Volume repletion will allow recovery from the shock state only when the bleeding has stopped. So your most important work is to locate and stop the bleeding point. Okay. Okay. So vasopressor are contraindicated as a first line treatment of hemorrhagic shock because it worsens the tissue perfusion. Okay, important negative line. Okay. So any injured patient with cool to touch and tachycardia should consider to be in shock until proven otherwise. Not that important. So tachycardia is defined as heart rate is more than 60 in infant, more than 140 in preschool child, more than 120 in children and more than 100 in adults. Okay. And elderly does not exhibit any tachycardia. So start from infant 160, then preschool child 140. Then children from school to puberty, it is 100, and in adult 120, and adult it is 100. Okay. So we have 100, 120, 140, 160. Adult 100, go children to puberty 120, preschool children 140, and infant 160. Important. That's why I'm repeating. Okay. And elderly does not exhibit tachycardia. So limited cardiac response to catecholamine stimulation or medication. That is the reason for elderly not exhibiting tachycardia. Okay. And or maybe it is due to pacemaker. So narrow pulse pressure suggested significant blood loss, and it involves the compensatory mechanism. So shock patient will have narrow pulse pressure that exhibit significant blood loss. So hemorrhage is most common cause of shock after injury. So there are few non-hemorrhagic causes of shock. Okay, the first one is cardiogenic shock. So myocardial dysfunction, it is maybe due to cardiac injury, cardiac tamponade, air embolism, or myocardial infection, MI. Okay. So all patients with blunt thoracic trauma need continuous ECG monitoring. So blunt trauma, patient blunt thoracic injury need continuous ECG monitoring. Important line. So let's see what is cardiac tamponade. It is most commonly seen after penetrating thoracic trauma. It is penetrating. Word penetrating is important. Okay. So clinical feature will be, all clinical features are important: tachycardia, muffled heart sound, and dilated or engorged neck vein with hypotension. Okay. And insufficient response to fluid therapy. Okay. So the tension pneumothorax mimic like cardiac tamponade, but there are a few difference. So tension pneumothorax is a respiratory problem, so you will get absent breath sound and hyperresonant percussion, and this is not present with tamponade. And echo and fast can will help you. So in tension pneumothorax you will get absent breath sound and hyperresonant on percussion. Okay. And cardiac tamponade is best managed by operative intervention. Pericardiocentesis only is temporary maneuver. So cardiac tamponade is best managed by formal operative intervention. Okay. So tension pneumothorax. So it is a true surgical emergency when air enter in the pleural space, but because of flap valve mechanism, it prevents the escape of that air. Okay. So you will see shift of the mediastinum, okay, to opposite side. Okay. Opposite side. Impairment of venous return and fall of in cardiac output, and patient will have extreme tachypnea and air hunger. Okay. So patient will have respiratory distress, subcutaneous emphysema, and absent unilateral breath sound. Okay. And hyperresonance to percussion, already told you. Okay. So patient need immediate thoracic compression without waiting for X-ray. Okay. By needle or finger decompression followed by placing a chest tube. Okay. In neurogenic shock, isolated intracranial injury do not cause shock unless the brain stem is involved. If the head injury patient have shock, so it is mainly due to brain stem involvement. Okay. So cervical and upper thoracic spinal cord injury lead to hypotension because of loss of sympathetic tone. Okay. So classical presentation of neurogenic shock is hypotension without tachycardia or cutaneous vasoconstriction. So narrow pulse pressure is not seen in neurogenic shock. Important negative point. narrow pulse pressure not seen in neurogenic shock. Okay. So it is treated initially for hypovolemia only. Then septic shock. In septic shock, the patient will have warm skin, near normal systolic pressure and wide pulse pressure. Okay, wide pulse pressure you will get in septic shock. Then hemorrhagic shock. Hemorrhage is most common cause of shock in trauma patient, told multiple times. Okay, so normal adult blood volume is approximately 7% of total body weight. Important line, 7%. So 70 kg male will have around 5 liter of blood. And the blood volume in child is calculated as 8 to 9% of body weight. So 70 to 80 ml per kg. Okay. So in adult 7%, in child 8 to 9%. In ml if you take, it is 70 to 80 ml per kg. Okay. Then we have the classification of shock. This is the most important of all topic in the shock, and every year you will get 1 or 2 question from this table only. So listen carefully. Class 1 hemorrhage. If any patient donated 1 unit of blood, so it will come under class 1 hemorrhage. So class 2 hemorrhage, uncomplicated hemorrhage. So uncomplicated hemorrhage, and it is managed with crystalloid only. Okay, crystalloid. So then class 3 hemorrhage. Okay, so it is complicated hemorrhagic shock and it is managed by crystalloid or blood also. Now class 4 hemorrhage, it is pre-terminal event. Okay, and it needs blood transfusion. Okay, so we have table. Let's see a table first. So there are 4 classes of shock. Class 1 is less than 15% of blood loss, and class 2 is mild, class 3 is moderate, and class 4 is severe. Okay, so class 1 less than 15, class 2 is 15 to 30, class 3 is 31 to 40, and class 4 is 40. So 4 is 40 and 3 is 30. You remember like that. Okay, and the base deficit is also important. So base deficit in class 1 hemorrhagic shock is 0 to -2, then -2 to -6 for class 2. In class 3 -6 to -10, and class 4 is -10 or less. So class 4 need massive transfusion protocol. A negative number is called base deficit and indicate metabolic acidosis. Okay, so class 1 hemorrhage less than 15% of blood loss, and you will see just minimal tachycardia. Okay. Class 2 is blood loss of 15 to 30%. Okay, you will see rise in diastolic blood pressure due to increased circulatory catecholamines. So rise in, okay, just remember rise in diastolic. Okay, and evaluate pulse pressure rather than systolic BP. So in class 2 the diastolic BP is important, and you have to evaluate pulse pressure, and urine flow is almost 20 to 30 ml. Okay, so class 2 20 to 30, just about 20 to 30 ml. Okay, it is managed with crystalloid. Okay, now come to class 3 hemorrhage. Okay, so class 3 hemorrhage, blood loss is almost 31 to 40%. Okay, and significant change in mental status, M looks like 3. Okay, and it is managed with blood and blood product. Okay, so and the class 4 is immediate life threatening. So you will see very narrow pulse pressure on unmeasurable diastolic BP. Okay, urinary output is nil, mental status is markedly depressed, skin is cold and pale, and rapid transfusion and surgical intervention, rapid blood transfusion and surgical intervention is needed. Okay. So there are confounding factors related to this all physiological changes. It depends on the age of the patient, severity of the injury, and type and anatomical location of injury, time lapse between injury and intervention, pre-hospital fluid therapy, and medication used for chronic condition by the patient. So it is dangerous to wait until trauma patient fits the precise physiological classification. Okay. So there are fluid challenges secondary to soft tissue injury. So fracture tibia or humerus, the loss of blood up to 750 of the blood. Okay. Okay. And femur, it is almost 1.5 liter. Okay, just double. In tibia or humerus, okay, 750 ml, and femur it is 1.5 liter, and several liter of blood can be accumulated in retroperitoneal hematoma associated with pelvic fracture. Okay, so pelvic fracture several liter, or in femur fracture 1.5 liter, and 750 ml in tibia or humerus. Okay. In obese patient, extensive blood loss in soft tissue even in absence of fracture. So elderly patient, because of they have fragile skin and subcutaneous tissue. So priority is stop the bleeding, not to calculate the volume of fluid loss. Then there is a gastric dilatation, mainly seen in children. So it will cause bradycardia from excessive vagal stimulation. So if unconscious patient gets gastric distension, okay, so it increase the risk of aspiration. Okay. So you may ask, in gastric dilatation you will see bradycardia or tachycardia. So it's bradycardia because of excessive vagal stimulation, mainly seen in children. So vascular access, too large caliber, minimum of 18 gauge in adult, because rate of flow is fourth power of radius of the cannula and inversely related to its length. So it's Poiseuille law. So we have to give short, large bore caliber peripheral IV lines. Short. Okay. We can also do intraosseous access, specially designed equipment possible in all age. Remember, it's all age. Intraosseous, you can go for all age. So if you give the fluid, so fluid, initial fluid you will give isotonic crystalloid solution. Okay, up to 1000 ml in adults, in children 20 ml per kg. So there are three possible response: rapid response, transient response, or minimal or no response. If there is a less than 15%, like type 1 shock, so patient will have a rapid response. Okay, so type 2 and 3 will have transient response. Okay, slight improvement, then again decrease, that parameter will decrease. Okay, and the minimal and no response will be class 4, that is severe. Okay, so shock does not respond to initial crystalloid fluid. What does it indicate? Generally 4 floor and 4 more. So they will ask, what is 4 more? 4 more is abdomen, pelvis, retroperitoneum, thorax, and extremity. Okay, so or other causes like non-hemorrhagic shock, begin blood and blood component replacement, and surgical consultation. So mainly this is important, floor and 4 more. 4 is abdomen, pelvis, thorax, retroperitoneum, and extremity. So balancing the goal of oxygen, organ perfusion and tissue oxygenation with avoidance of rebleeding by the accepting a lower than normal blood pressure. So balance lower than normal blood pressure. So this is also called controlled resuscitation, balance resuscitation, or hypotensive resuscitation, and permissive hypotension, in which early resuscitation with blood. Okay, this is mainly done in type 3 and 4 hemorrhage. Okay, urine output is one of the prime indicators for resuscitation and patient response. This question asked in NEET PG multiple times. So what is normal urine output for this trauma patient? In adult it is 0.5 ml per kg per hour, and in pediatric patient 1 ml per kg per hour. If the infant like age under less than 1 year, it is 2 ml per kg per hour. So we have 3 value, 3 age group: adult 0.5, pediatric 1 ml, and infant 2 ml. So if the trauma patient develop the metabolic acidosis from the hypovolemic shock, do not use sodium bicarbonate to treat this patient. Okay. This is also already explained the response to initial fluid, rapid response. So rapid response, class 1 hemorrhage. Okay. Then transient response, then minimal and no response, failure to respond the crystalloid and blood. Okay, so this patient need immediate definitive intervention like operation or angio embolization to control the bleeding. Okay, mainly seen in class 4 hemorrhage. Okay, now cross matching of the blood. Complete cross matching process require approximately 1 hour. Even Bailey and Love say 45 minutes. If cross match blood is unavailable, then we can go for O type of PRBC. It is Rh negative blood, mainly in female of childbearing age group. Okay, so how to prevent hypothermia? So most efficient way to prevent hypothermia in any patient receiving massive resuscitation of crystalloid is blood to heat the fluid to 39 degrees Celsius or 102 degree Fahrenheit, 39 and 102.2. So heated by passage through the intravenous fluid warmer. Okay, auto transfusion. If you are planning to give auto transfusion, the anticoagulation should be sodium citrate rather than heparin. Okay, so auto coagulation when we are doing, the sodium citrate should be anticoagulation agent, not heparin, and mainly this is mainly done in massive hemothorax. So massive transfusion. What is massive transfusion? More than 10 units of PRBC within first 24 hours of admission, or more than 4 units in 1 hour. Okay, so in massive transfusion we have 1, 2, 4 and 10. In 1 hour 4 units, in 24 hours 10 units. Okay, if you just cut it and write 1 day. So in 1 hour 4 units, in 1 day 10 units, more than 10 units. Okay. Then early administration of PRBC plasma and platelet in balance ratio. Okay, 1:1:1. So balance, hemostatic or damage control resuscitation. Now coagulopathy. So PT, APTT and platelet count should be done in first hour if the history of coagulation disorder or who takes medication for alter coagulation. Okay, so tranexamic acid given within 3 hours. Okay, the first dose is usually given over 10 minutes, followed by 1 gram given over 8 hours. Okay, so increase in blood pressure should not be equated with the concomitant increase in cardiac output or recovery. So elderly patient will have deficient in the receptor response to catecholamine, already told. So hypothermia, esophageal or bladder temperature is an accurate clinical measurement for core body temperature. Okay. So core rewarming techniques are irrigation of the peritoneal or thoracic cavity with crystallite solution warm, that is 39 or 102.2 degree Fahrenheit. For severe hypothermia, we do extracorporeal bypass. Okay, and hypothermia is best treated by prevention. So this is more important line. Severe hypothermia is treated by extracorporeal bypass. Okay. Okay. So inadequate volume replacement is most common complication of hemorrhagic shock. Undiagnosed source of bleeding is the most common cause of poor response of fluid therapy. So this was for chapter number 3. The most important in chapter number 3 is types of shock. Okay, and their clinical feature. Ask multiple times in examination. This table, not this table. This table is the most important. Thank you.